we are going to cut right through the noise on metacarpal fractures. We're going to focus on the high-yield, evidence-based principles that you can actually apply on your next call or in your next clinic. So here's how we're going to break this down. We'll start with the anatomy that really dictates the fracture patterns we see. Then we'll get into that key decision to operate or not to operate. From there, we'll cover some really important non-operative pearls and a guide to fixation before wrapping up with a special case of the thumb. All right, first up, let's talk anatomy. But we're not just going to list a bunch of parts. We're going to focus on the biomechanics. This is all about understanding the why behind those typical fracture patterns you see on every single X-ray. Okay, you have to think of these attachments as a constant game of tug-of-war. The intrinsic muscles, they are always pulling that metacarpal head volarly towards the palm. The transverse ligaments, they act like a check rein, resisting any shortening. And then you have these powerful wrist tendons like the ECU and the APL. They are the direct culprits for the classic deforming forces we see in those base fractures. All this anatomy leads us to a really fundamental question, one that explains the most common deformity we have to deal with. Why do these fractures almost always angulate apex dorsal, with the point of the break sticking up? It's not random at all. And here it is. The answer is actually pretty straightforward biomechanics. The intrinsic muscles pull from below the joint's center of rotation. That powerful volar force flexes the distal fragment, and boom, that's what creates that classic apex dorsal angulation pretty much every single time. Okay, so with that foundation, let's get to the million-dollar question you face in the clinic or when you're on call. Which of these fractures truly needs a trip to the OR? The literature actually gives us some really clear number-based guidelines. This is a big one. Crucial for your boards, crucial for your practice. Any shortening that's greater than 5 millimeters is a key indication for surgery. And why is that? Because that much shortening can seriously disrupt the balance of the whole extensor and flexor system, and that leads to real functional problems for the patient. And here's the other magic number you've got to burn into your memory. This one's for intra-articular fractures, fractures that go into the joint. Any step off over 1 millimeter is a strong indication to operate. You just have to do it to prevent painful post-traumatic arthritis down the line. Now this slide, this is pure gold for board prep. These are the key numbers for acceptable angulation. And the critical principle here is that we can accept way more deformity on the ulnar side of the hand. 70 degrees of angulation in a small finger neck fracture, that's often totally acceptable. Why? Because the mobile 4th and 5th CMC joints can compensate. That's just not true for the very rigid index and long fingers. Now, while we can accept a surprising amount of angulation, especially in that little finger, this right here is the absolute non-negotiable rule. Malrotation is not well tolerated by the hand. Any degree of it will cause the fingers to scissor or overlap when a patient makes a fist. That is a huge functional problem. It has to be corrected surgically, period. So what about the majority of these fractures, the ones that don't meet those operative criteria? Let's dig into the best way to manage them. And I gotta say, the evidence here might actually surprise you. It definitely challenges some of that classic teaching. So if you do need to do a closed reduction for a metacarpal neck fracture, the JAS maneuver is the classic technique to know. By flexing the MCP to 90 degrees, you tighten up the collateral ligaments. This tension allows you to literally use the proximal phalanx as a lever to push that metacarpal head right back into place. But now check this out. This is a huge clinical pearl, coming directly from the author's commentary in one of the source articles. They argue that for a lot of neck fractures, even with pretty significant angulation, trying to do a reduction that's tough to hold is often just unnecessary. Their practice is to prioritize early motion instead. And you know what? The literature strongly supports this, especially for boxers' fractures. Study after study shows no difference in outcomes between immediate mobilization and weeks stuck in a cast. So the big takeaway for stable, extra-articular fractures is this. Early movement is safe, and it gets patients back to their lives faster. All right, let's switch gears. For those fractures that do need surgery, let's organize our thinking. It's like we have a toolbox, right? We've got a variety of fixation options, and picking the right one really depends on the fracture pattern, the soft tissues, and, of course, the patient. When you really look at it, this all boils down to a core trade-off. On one end of the spectrum, you've got percutaneous pinning. It's minimally invasive, but it's also less stable. On the complete other end, you have plates. They're super rigid. They allow for early motion, but it comes at the cost of more soft tissue stripping and the potential for tendon irritation. All your other options, like screws and IM nails, kind of fit somewhere in between.
So if we drill down and compare the two most common internal fixation methods, the evidence gives us some interesting nuances. For that classic boxer's fracture, multiple studies actually suggest that intramedullary fixation might lead to a better and faster functional recovery. But for other extra-articular shaft fractures, well, the comparative studies haven't found any significant difference in the final outcomes between IM nails and plates.
And here's what that looks like in the real world. This is the author's practical, boots-on-the-ground approach, synthesized from all that evidence. For neck fractures, they prefer minimally invasive techniques that spare the extensor tendons, like IM nailing. But for a really displaced shaft fracture, where getting a perfect reduction and rigid stability is absolutely paramount, they'll opt for a plate. Finally, let's talk about a special case, the thumb. You really can't treat these like other metacarpal fractures. The unique saddle joint and the incredibly powerful deforming forces at play here mean they get their own classifications, and they require a totally distinct management strategy. So the most crucial point to understand about a Bennett fracture is that it is inherently unstable. It's really a fracture dislocation. That tiny beak fragment stays right where it's supposed to be, held by its ligament, while the powerful abductor pollicis longus tendon literally pulls the entire rest of the metacarpal shaft off the trapezium. And that's exactly why non-operative treatment almost never works. When it comes to fixing a Bennett, you've got two main choices, percutaneous pinning or an open reduction with a lag screw. Now, surgeons often have really strong preferences one way or the other, but here's the kicker. A key study with a 7-year follow-up found absolutely no difference in outcomes. Pain, range of motion, strength, they were the same. So the choice, at the end of the day, comes down to surgeon comfort and the specific fracture anatomy.
Now, if a Bennett is a problem, a Rolando fracture, well, that's a whole different level of difficult. Instead of that one large, predictable fragment like you see in a Bennett, here the joint surface is just shattered into multiple pieces. This comminution makes it incredibly challenging to get a stable anatomic reduction, and for that reason, the prognosis is much more guarded.
For these really tough Rolando fractures, your game plan totally depends on how big the pieces are. If you've got enough bone to work with, a plate can be a great option. But if that joint is just shattered into tiny pieces, external fixation becomes your best friend. By distracting the joint, you use something called ligamentotaxis. You're letting the intact ligaments pull the fragments back out to length and help mold that articular surface back into shape. And that really brings us to a final, very practical point. While the evidence gives us some really clear rules for things like rotation or an articular step-off, for many of these fractures, there are several perfectly valid treatment options. As the source literature confirms, when that high-level evidence is lacking, the ultimate decision is often guided just as much by surgeon training and personal experience as it is by the data itself.